requested some things about some Bell's palsy, right?
Yeah,
Yeah, so let's bring can you see the screen?
yeah, I can see the screen. You can see your
Okay,
slides. All
great,
right.
great. So this is an old, so it's funny that, so I don't know if you've probably seen these before. We've talked about these before where the Academy puts out these clinical practice guidelines. And it's basically about other specific topics in otolaryngology that are basically key action statements, recommendations for management, and they are based on the literature of the day. So this actually came out over a decade ago, but interestingly, I'm chairing the revision of this, which is going on now. So there'll be an update to this guideline coming out in probably 2026. Yeah, this one came out in like 2013, 12, 13. So it's well over a decade older. But still, a lot of these principles are still pretty obviously common things that we do. So not a ton has changed, but we'll go through this. So okay, this is just some of the stuff we use. So when we talk about acute onset facial paresis or paralysis, there's a few things obviously it's really important to be aware of. And many times it's just simply, how are you describing this, the diagnosis, right? Because there's many things that get misconstrued as Bell's palsy, which in fact it's not, which can be dangerous because sometimes it can be a neoplasm, it can be tumor affecting the facial nerve, and patients get misdiagnosed or mislabeled, and then they get mismanaged, right? Especially when it comes to cancer, that's certainly a problem. It's not a problem. It's a problem, obviously, any other way, but especially if it's something that could be life-threatening. So we're going to go through some case scenarios and talk through using scenarios and I'll ask you guys some questions about how you would manage some of these things. And then based on the key action statements, we'll go through sort of the best practices of the day, at least at that time, 10 years ago. Okay. Okay. So if you have a 75-year-old comes to the ER with a facial droop, they kind of woke up with a left facial droop and slurred speech. Gift, since you're sitting there, what are you going to ask about this patient? What do you want to know about this patient? And what are you specifically looking for?
So basically, I want to know, I want to ask the progression of symptoms. They were just an acute onset in one morning. And I want to find out if the patient has any preceding history of any, say, upper respiratory tract infection or any form of infection or any ear discharge prior to presentation or any otalgia. I also want to find out if the patient had any history of immunosuppression, any history of diabetes mellitus, if their sugars were controlled, if they were diabetic. Yeah, I think for now, that's what I was asked.
Okay, someone had a left facial droop and slurred speech. What would be the most ominous thing you'd be worried about? What would be like the worst case scenario you'd be thinking about? If you just heard that, and you haven't really seen him, like you're getting a phone call, Gift, hey, patient in the ER, 75-year-old, they got a facial droop and slurred speech. What's your first thought?
So I would be worried about a stroke.
Yeah, a stroke, right? Yeah, so you'd want to ask, do they have any other peripheral issues? Do they have any upper or lower extremity weakness? Do they have any, is there any other, extremity problems, neuromuscular problems? Are they responsive, et cetera, et cetera? Exactly, right. So the first thing I think is the most ominous thing. And then all the things you've asked, absolutely. So keys are, you want to try to rule out other things that could be causing this. So first of all, your first thought is this central or peripheral, right? Is this your first one to think, okay, let's rule out, make sure there's nothing central, stroke. And then if you think, is this peripheral, meaning this is, outside the brain and the brainstem, what are the other issues? Do they have any ear history, otorrhea, trauma, infections? Are there any medications taken? any infectious disease exposures, et cetera, et cetera. Yeah. So you kind of want to make sure you rule out the big thing first. So one of the key action statements is this is kind of an obvious thing is you have to assess with a good history and physical, right? Acute facial paresis or paralysis. So obviously it's really important to take a good history and a physical. Okay. So on a patient like this, can you talk me through, Gift, what would be if I came in and I had if I had a paralysis or I had unilateral symptoms on one side of my face, how are you going to tell the difference between a central or peripheral lesion? How are you going to immediately tell if it's something that might be worried about stroke versus maybe what we'll describe as Bell's palsy?
Okay, so basically I want to differentiate between an upper motor neuron lesion versus a lower motor neuron lesion. So in the case of a facial nerve paralysis, I want to see if there is unilateral complete facial nerve palsy with no frontal sparing for a lower motor neuron lesion. And if there is frontal sparing on that particular side, I'll know this is probably an upper motor neuron lesion. And that will kind of give me an indication to a central cause. And then I'll also want to rule out any other focal neurology like hemiparesis, hemiplegia, any other cranial nerves that are involved besides the facial nerve, like your trigeminal and any other cranial nerves that can direct me towards a central cause like your dangerous Ds, dysarthria, dysphagia, just to make sure that we are dealing with an isolated lower motor neuron lesion, which is more common, which is a clinical feature of Bell's palsy.
Mm-hmm. Yeah, so the key is the forehead sparing, right? So if they had forehead sparing, that tells you it's likely a central cause, right? Because you have bilateral innervation versus a lower motor. Now, as you mentioned, if you get unilateral weakness, then it doesn't have to be complete paralysis. If you have weakness, then that's a big tip off there, right? And slurred speech, what are the two causes that could be slurred speech? We talked about slurred speech, but you said a key word there. Why would all people with a facial weakness and slurred speech have a stroke because of the slurred speech? Is that the case? Or why, I guess my question is, could someone who has a Bell's palsy have a slurred speech and why?
I think it's all to do with the effect of the facial nerve palsy on the oral, on unilateral orbicularis orin, where you are not symmetrically going to be able to produce. So I think the lips is all to do with the lips. Your kind of your slurred speech comes because your mouth is going to be skewed, and you will not be able to pronounce words correctly, to articulate words better than when you don't have a facial nerve palsy. But right. I if you can differentiate it from, say, your glossopharyngeal and vagus palsy in stroke, you might not be able to kind of differentiate the two.
Yeah, they can be a little bit dysarthric, right? So the issue is, like you said, oral commissure collapse, the tissues are falling. Obviously other things you want to look for is tongue mobility, look at hemiatrophy of the tongue, or does it deviate to one side? It might indicate that they have something else going on. But yeah, so that's another reason they might have some changes in speech. Yeah. So it's key here. Yeah. So you've hit on it, a good history, timing, other contributing symptoms or findings, cranial nerve findings, history, all very important, obviously, and then to rule out central versus peripheral causes. Okay. So that same person that came in, are you going to get lab testing? So who else is in the audience there? Sorry, I can't see Amina. And then, so Amina, why don't we
Yeah.
ask you? So are you gonna, in this person that comes in, are you gonna get some lab testing? And if so, what are you gonna get?
So just back on the history, do we have any other chronic illnesses, hypertension, diabetes, any immunosuppression, any chronic medications that we are on, dyslipidemias, because this would guide the lab testing a bit. They'll also on examination, we'll do a full cranial nerve exam, but also look out for features like fevers, any pain that they have and where they have the pain. I would be very interested in knowing about the ear. Do they have any pain in the ear? Do they have a discharge? Have they had any history of trauma? Because all this is going to dictate what kind of testing I'm going to do. If all the above is normal in the history, then on the exam, still do a full cranial nerve exam, but examine the ear to look for any features of infection in the ear, any vesicles, perforations, or discharge. Routinely, if I don't find anything, a basic lab test would be maybe a full blood count to look at septic markers. More particularly, look out for lymphocytosis to point towards a viral infection, but routinely we wouldn't do lab testing for these patients. Unless you have something that you're particularly investigating for. I'm not going to send these patients for a full lab panel of CBC, liver and renal functions, lipids. We wouldn't do that in our setting.
Right. No, you hit it on the head. Exactly. So unless physical findings or vitals are, indicate or mandate that, you're absolutely right. There's so lab testing really shouldn't, routine lab testing really shouldn't be performed in Bell's. Now there's some interesting things. Now, what if somebody presented with a bilateral facial paresis or paralysis? What do you think about that? And does that change your answer to this question?
Yes, bilateral would change my thinking. First of all, bilateral is very unlikely to be Bell's palsy, but some of the causes of bilateral palsy, like Lyme disease, some syndromes like the Rosenthal-Mackerson syndrome, there are few particular things that are going to give you bilateral facial nerve palsy, and you would direct your testing to that. I think for Lyme disease, there are antibody markers that are tested for. So you would direct your investigation based on that, because bilateral facial nerve palsy is very unlikely to be Bell's.
That's right. Absolutely. So you're absolutely right. So this is in routine testing, and we'll define Bell's in a moment, is you're absolutely right. It's more of a unilateral problem. So you want to be highly suspicious if somebody comes in with a bilateral facial paresis or paralysis. That's highly suspicious because for Bell's to affect both sides is pretty much unheard of. I mean, nothing's completely zero, but that's pretty close to zero possibility of that. So it makes you really start to think about other things. And you're absolutely right. So currently there's really no lab tests that we would get for this. Some people I've seen, when people come to the ER, they do a lot of these early markers of inflammation like sedimentation rates and CRP, C-reactive proteins, and things like this. And as you guys know, those are oftentimes just spurious. They can be elevated with medications. If the patient was sedentary for a long period of time, there's all kinds of things that can elevate that. So, and you're never really going to treat that number anyway. You're treating the symptoms and the clinical findings. So again, yeah. So no real testing for this. Okay. So if we describe, well, I guess so, Gift, how would you define Bell's palsy? So if you had to, if one of your colleagues is like, how they say, you say to the ER doc, I think it's Bell's palsy. And they're going to say, well, why? Can you provide a definition for me? How would you define it?
So I'll define it as an idiopathic unilateral facial nerve palsy of sudden onset.
Okay, is it just a palsy? And what do you mean by sudden onset? What's a palsy? Is that, can you be more specific? And can you be more specific about the sudden? What do you mean by sudden?
I mean, I can help it.
Yeah.
I'll have to redefine myself, but
Yeah.
what being sudden, I think of acute onset within, I think within, with no prior history of any, any. I think it's not gradual onset, it's an acute
Right, so
onset.
right, so yeah, so right, so it's sudden, but yeah, can you be more specific? So if you need it, so Amina, what do you think?
I think acute onset of unilateral facial nerve weakness. That is idiopathic.
What's another word for facial nerve weakness? So Gift said palsy. What is palsy a facial weakness?
Paralysis.
Okay, so
Paralysis.
if my face is completely out versus partially out, can you tell me what words would you use to describe a complete weakness or complete lack of function versus partial function?
Oh, and maybe it's not international, but here if it's complete, we'll say complete facial nerve fallout. And then if it's partial, then we'll say paralysis, and then we'll grade that based on the House-Brackman.
So maybe you can say paralysis, which is complete fallout, and paresis, which
Yes.
is weakness.
There you go. That's what I'm looking at. Paralysis is like it's gone, right? There's nothing. If you use the House-Brackman, it's a 6 out of 6, right? Paresis portends weakness, but it portends not paralysis. Does that make sense?
Yep.
That's really important. So another important thing is this. So let's say you're in the clinic, and let's say I come in with ear pain complaint. And in your note, you look at I have no other findings, okay? And my ear is fine, okay? And you're documenting all my cranial nerves. How are you going to document my facial nerve? I'm curious, how would you, in the note, document my facial nerve function? What would you say? Again, it's normal. Everything, I have no head or neck findings. And so you're writing me up in your clinic note and you're saying cranial nerves. Specifically, I want you to comment. Well, how would you describe my facial nerve function? What would you say?
Normal facial nerve function.
Okay. All right, Gift, would you say anything else? I wouldn't want to
apply. Yeah, I wouldn't want to apply House-Brackman grading on a normal functioning facial nerve. Though we say that on House-Brackman, 1 is normal.
Okay. So what is the House-Brackman scale for? Sorry, I mean, this is a little bit of a particular thing. It's really kind of important. Is the House-Brackman scale a scale of baseline function, or is it a scale of recovery?
I think we use it for us if we have a patient that who is presenting with a facial nerve fallout. We'll give the facial nerve paralysis or paresis a House-Brackman grade, and we will use that to predict recovery,
right?
To also monitor the patient if there's any improvement.
Right. So you're applying it to someone who may have incurred some kind of a insult, right? Right. But for someone who has no, so I guess what I'm driving at is for someone who has normal function in a clinic setting or whatever encounter, we don't really apply the House-Brackman scale to them, right?
No.
It's after some kind of insult, right? Because then we're using it to describe something, right? So typically, if someone came to the clinic, I would never say, if they had normal function, I'd never say House-Brackman 1 out of 6. Because that portends maybe they had something and they recovered back, right? So I would just say their facial nerve is intact and symmetric in detail. Intact and symmetric in detail. I mean, it's bilaterally. I don't apply the House-Brackman for that. Now, if they came in and they had a previous Bell's palsy, and maybe they're graded at a 3, and now I see them back 3 months later, and then they got normal recovery, I'd say, oh yeah, they're a House-Brackman 1 out of 6. Right? Does that make sense?
Yeah, it does.
So, I mean, traditionally, I think people apply it. I think that was traditionally how it was expected to be applied. Brad, do you agree with that?
Yeah, I do.
Yeah. Yeah. So I think you have to be careful about that. So in your notes, it can be misleading, is my point. Is if you say the patient's 1 out of 6, then you're saying, oh, what happened to their face? Something happened to their face at some point. Does that make sense?
Yeah.
So if they've never had any facial nerve problems before, I usually just describe it and say, well, it's intact and it's symmetric in detail, meaning all branches. I'm not going through each one. I just say symmetric and intact in detail means it's covering all the 5, divisions there on the extratemporally. Okay, good. So to get back to our definition, Bell's palsy is a sudden, and what people will say is it has to manifest itself within 72 hours, right? So it has to go from whatever it started to wherever it's ended, typically within 72 hours, while excluding any other possible cause. So Gift, you're right, it's idiopathic, right? Because to be Bell's, you have to exclude any other cause. If someone's got a draining ear and a mastoiditis and the face dropped out suddenly, that's not Bell's palsy, right? While it met the guideline or the criteria for the onset of timing, there's other potential causes, right? So it has to be that quick onset within 72 hours, but it also has to be without any other possible findings. So idiopathic, right? And so that's really the important distinction here. Timing is everything, and ruling out other possible causes is everything here. Unfortunately, Bell's get slapped on a lot of diagnoses, and that's the problem, right? Someone who has a progressive loss that's gone way beyond 72 hours gets labeled with Bell's, and they might have a occult squamous cell carcinoma or an expleomorphic adenoma. Now now it's a squamous cell cancer, right? Or some other perineural invading tumor, right? So that's really important. Timing is so important. Okay. All right. So now that same patient, we're still dealing with the same patient. You've decided that it's peripheral. It's not central. You don't think they've had a stroke. Rest of the head neck exam is normal. There's no other findings to suggest a central problem at all. No other medical concerns or history. You haven't drawn any labs. Vitals are stable. Are you going to get imaging on this patient?
No.
Well, let's poll the audience. What do your colleagues feel? Gift and everyone else in the room? Is it just the 3 of you guys? What do you guys? What else do you guys think? And don't be afraid to disagree with Amina. Okay. Doesn't mean you're right, but it doesn't. But I'm just. What do you guys think? Would you guys get imaging on this patient?
So once you rule out the more sinister cause, you said or the CT or rule out a hemorrhagic stroke. And are you not thinking that there is a stroke? I wouldn't order any other imaging if you're thinking there's a peripheral cause.
Yeah, you ruled everything out, and you're feeling pretty confident. There's no forehead sparing. Peripherally they're fine. There's no extremity weakness or focal neurologic findings. No other findings. No other findings, other than the facial paresis here.
Yeah, and I wouldn't order imaging in that case.
Okay, Gift, what do you think?
I agree with Quincy. We wouldn't routinely order imaging. I think the role of imaging is when you are not very sure about whether you're dealing with a peripheral or a central cause. But otherwise, if you've ruled out all the other causes and you're confident that it's peripheral, there's no role for imaging.
Okay. Brad, what do you think?
We probably would because of the age, 75 years old, and just to make sure that we weren't overlooking something, but I don't know that it would fall in the guidelines and probably isn't necessary, but we probably would get an imaging.
Yeah.
If they weren't 75, if they're 35, I probably wouldn't.
Yeah. Yeah. So the point of this is, and you guys were right, and again, he's bringing up as a special circumstance here. Yeah, is the age, is there something else? But typically the guideline, the data suggests that if you've ruled everything out clinically, you should not routinely get imaging. Okay. If you did, can somebody comment? So let's say you get an MRI scan, you get a fine cut through the inner ear, you get a seventh nerve protocoled MRI, if that's available. What are you going to see on that? What do you guys think you might see on this? Can you describe what you might see? So anyone, you guys can answer, except Brad. What do you guys, what do you think you might find on the MRI? Not a trick question. I'm not talking about the 75-year-old or anything like that. Talking about anybody who comes in with this at any age, what do you think you might find?
So on T2 weighted imaging, I would expect to have normal brain pathology. I'm curious.
Normal brain pathology. What is normal?
Normal brain findings.
What is normal pathology?
Sorry,
I had to. You gotta.
I'm low on my coffee. I am low on my coffee. No, but I would expect to find normal brain tissue. I'm curious if we'd be able to pick out inflammation along the facial nerve. I'm not sure if that can be picked up on a T2 weighted image, but if we are able to look at the nerve, especially the maybe canalicular segment, maybe we can pick up inflammation there. I'm not sure.
How would that? What imaging modality would you look for that? You said
inflammation would light up on a T1 weighted image.
T1 weighted alone, or would they require something else?
Maybe diffusion weighted as well. Imaging, I'm not sure if that would pick up inflammation, or maybe the flare. I'm not sure. I'm not sure what.
I guess I'm driving. Would they require contrast?
Yes, with contrast.
Yeah, we're likely with contrast.
With contrast.
Yeah. So typically you're probably going to see that. Exactly right.
Is there a specific sequence that I'd have to ask for on the imaging?
Now, usually a T1 weighted with contrast, like a fine cut. If it's a brain MRI, sometimes the cuts on that are a little too thick and you might pass over. And you said it correctly, potentially the labyrinthine segment, but really technically any area of the facial could show some enhancement consistent with possible inflammation, but you're going to see it likely near the labyrinthine segment or parageniculate areas more so. But yeah, you probably expect to see that because even though we say it's idiopathic, what do we think is the underlying cause for Bell's palsy? Kind of at the heart of it, what do we think?
The theories that have been advanced, one is inflammation along the nerve, and then
secondary to what?
The big theories of latent viruses within the geniculate ganglion that get activated later to give a viral inflammation, like a perineuritis in the nerve. But there's also been a theory, especially when it's labyrinthine segment and the blood supply gets cut off in that segment. But all these are theories that have been advanced, and some research disputes then?
Right, so we think it's viral, right? So gift, if it's viral, what part of the facial nerve? So first of all, any kind of particular viruses that you can aware of that people have thought about? And then what part of the facial nerve is most susceptible to inflammation and why?
So, first of all, I would probably think, I would probably say the virus that has been implicated is your HSV and measles virus. And the more likely part of the facial nerve in its course that's more likely to be more vulnerable to inflammation is the labyrinthine segment, and followed by the geniculate ganglion. So the labyrinthine segment is narrow and short, and also is not covered completely by which is periural perineurium, yeah.
So you're right. So yeah, measles, I'm not sure if that's, but most people think about like, yeah, like maybe a herpes type virus for sure. And labyrinthine segment, definitely, right? Because I think it's the narrowest portion of the facial nerve where the actually fallopian canal begins in the meatus and the lateral IC. And so they think it kind of almost like incarcerates itself with inflammation, right? So that's the rationale behind that. Yeah, exactly. That's why we give steroids. Right. Okay, good. Okay, great. All right. So if you get imaging, right, if you've ruled everything else out, the idea is that you're not likely to find anything, and you might just see an enhanced area of the facial nerve, which is not probably going to change your management, which we'll talk about. So unless you have some other concerning finding, and Brad brings up a good point, is maybe somebody's a little bit older, potentially is there something occult going on there that you're not seeing clinically? So I think you have to use a clinical judgment. That's why we said you should not routinely perform diagnostic. Doesn't mean that you can't or you shouldn't. It just says routinely, right? So that basically is saying that everyone who walks in the ER or the clinic with a facial paresis or paralysis should be getting imaging. Okay. All right. So you have a 45-year-old woke up with a facial droop, can't move her face voluntarily, can't close the eye. So immediately you're thinking of what? I'm sorry, I completely forgot your name. That gift there on Quincy. Quick question. So without reading anything further, we already have a facial nerves compromised. We don't know why, what else is going on. If I told you that they couldn't move the face and they can't close the eye, can you tell me at least what House-Brackman level they are? 1 out of 6.
So at least 4 and probably 5, because they can't close the eye. If you can see the finger asymmetry at rest, I'd say 5.
Okay. What if she could close the eye? What is she at least better than?
So if she can close the eye, she's at least 3 or better, I believe it is.
There you go. Yeah, exactly right. Good. You got it. So 3 or better if she can close the eye, 4 or worse if she can't. Good.
Mhm.
So she has no significant medical history, no other symptoms, no other events. Exam is normal other than this paralysis. So now you have no discernible movements across all the divisions. So what do you think our House-Brackman scale is?
No discernible movements, then our House-Brackman is a 6.
Okay, good. All right, so are you going to, what are you going to do to counsel her after you've ruled everything out? And I kind of gave you the hint here.
So with the caveat that I've done a full history examination, I've ruled out any central causes, and I'm confident this is a peripheral cranial neuropathy. And I'm thinking that this is potentially a Bell's palsy. I would counsel her that in that case, early prescription of oral steroids is probably the best thing for her, because we think that Bell's palsy tends to have better results when you give patients early oral steroids and high dose oral steroids. I think it's at least, I think we give 1 milligram per kilogram. So early oral steroids are shown to have better benefit for these patients. And then would actually give her steroids at least for 2 to 3 weeks and see her again. I would also that the majority of patients actually improve with early oral steroids. I think it's 80 to 90% of patients, but I could be mistaken on that figure. And we will review her and see how she does. But that the majority of times with oral steroids, patients receive get some benefit.
Okay. So a gift question, good. So what if she says, you know, I'm a brittle diabetic, I can't tolerate steroids, and every time I've taken them before for other reasons, I get all jittery, I can't sleep, I get bad reflux, my hip hurts. And you're like, oh geez, wow, maybe we can't give her steroids. And she or she refuses them. How are you going to counsel her? What would you say to her? Based on, if she says, well, doc, I mean, what's going to happen to my face? If I don't take the steroids, what's going to happen? I mean, I'm worried. I want to take them, but I can't take them. Shouldn't take them. What's going to happen to me? Can you, how would you counsel her?
Sorry, is that for me? Oh, okay.
Yeah.
I would
Oh, no,
still
I'm sorry.
say.
I'm sorry. I let you off the hook. I threw that one to gift. Sorry.
Okay, okay, all right.
I let you off the hook. You did a great job on that last one. I didn't want
Yeah,
Gift falling
so-
asleep. I didn't want Gift falling asleep on me there. He was starting to head nod or something. We better.
So from my understanding, I understand that for almost over 80% of those patients will recover spontaneously. So
Recover to what? When you say recover, what does that mean?
at least to I wouldn't say complete, but they will recover to at least 3 house Brackman 3 if they presented with a house Brackman 6 without any intervention.
Okay.
So
Over what period of time? Is that over a
Well-
year? Is that over 5 years? Is that over 10 minutes? Is that over?
yeah, I'm not very, I'm forgetting exactly the time frame, but I think from a month to 6 months.
Mhm.
Yeah, if I may put a guess.
Okay.
Yeah, but my understanding is steroids will probably help with inflammation and the time the palsy or the weakness takes to get better.
Right.
In an acute setting. Yeah, that's my understanding. And whether you should give it up to 3 months, I think you can give it, I think you between 7 to 14 days, within 72 hours of
Mhm.
the facial nerve paralysis happening.
Mhm. Yeah.
So in
Right.
terms of steroids, if they are really contraindicated to taking it, I think you can omit them. I don't know if you should really push for them. I don't know. Do you really need to, if they can't have it? It's very difficult for me to say, but I would probably just tell them that the difference that comes in with taking oral steroids is the time to recovery or immediate intervention, and that helps with kind of quick recovery as compared to not taking anything.
So there's a landmark study that was done in Scandinavia like 30 plus years ago. I think it was by Peterson et al. And they showed that in absence of treatment, you're absolutely right. Over 80% of people recover back to like a House Brackman 1 or 2, if it's truly Bell's palsy. So if natural history is anything to consider here, that's actually a good thing for her if she can't take the steroids, that her chances, if she's otherwise healthy, no other issues, but she's going to likely get some recovery. Okay. And that's usually within a 3-month span. Okay, so 3 months is really an important thing. If you're not seeing meaningful recovery within 3 months, that's an indication to get imaging. Or if they worsen their House-Brackman's grade over 3 months, that's another reason to get imaging. So the caveat to imaging here is if they don't recover meaningfully within 3 months, something, or show signs of recovery, or if they worsen in their grade within that 3-month period, you definitely need imaging. Okay, steroids, right? We definitely recommend steroids. Studies are pretty clear that those are important. Regardless if they get steroids or not, what's the most important thing you're going to counsel to this patient, though? There's something that you got to tell them no matter what they do right now, whether they take steroids or not. What do they need to be doing right now? Anybody?
What do they be doing?
What's that?
You said, what do they need to be doing?
What do they need to be doing right now, regardless if they take steroids or not? What's the most important thing they should be doing right now?
So usually,
Go ahead.
yeah, when they come in, especially for this patient, we always talk about eye care. To avoid them getting a conjunctivitis. So we give them natural teardrops. We encourage them to take the eye shut at night. But also, even if we give them steroids, we always counsel them about a possibility of never getting full recovery again. So because in a particular percentage, even when you give the steroids at 3 months, you might still have a House-Brackman 6. It's a very small percentage. We also, there are exercises that they can do to try and improve the tone over time. So here they have them blowing into balloons to try and increase the tone of their facial muscles as they take the steroids.
Mm-hmm. Yeah. So eye care is what I was getting at. The eye care is the most critical piece. They got to be using artificial tears, lacquer lube, tape the eye, humidified eye chamber, good eye exam if they need it. You can't get corneal desiccation. That can be, vision threatening. So no matter what, during the recovery, the eye care is critical. Exactly right. So so this is obviously it. So you definitely want to prescribe oral steroids within the 72 hours if you can. You want to get that on board quickly. And usually we do a burst. I usually do a burst and taper. Now, honestly, I don't see many of these patients. And I would imagine Brad doesn't either. A lot of us in the clinic, these patients have come through an ER, primary care doc. So, and then if they have residual facial issues, sometimes they're following with my facial plastics colleagues. So it is so rare for me to ever see one of these folks in the clinic. I might see a different variety of facial paralysis in the clinic that would be sudden, that's not tumor. Can you give me an example that could affect other parts of the head and neck that would be relevant to us? Any thoughts?
Ramsay-Hunt syndrome.
What is Ramsay-Hunt syndrome?
So Ramsay-Hunt is a triad that involves facial paralysis. They have a vesicular rash within their ear, and they also have
What other structures? What other structures live in your ear that could be involved?
So your facial nerve, their facial nerve palsy or paresis, they have hearing loss, and then on examination they have a vesicular rash in their either ear canal or concha ball following the distribution of the sensory branch of the facial nerve.
Right. So that's a much more ominous problem, right? So that'll be more of a neurologic issue, right? So what causes that? Is that herpes? Or is it what?
Reactivation of herpes zoster.
Zoster, right? So it's basically shingles in the head and neck, right? But it can be devastating, right? It can affect the facial nerve, but also it can give you a complete dead ear. It can give you a peripheral vestibulopathy, complete hearing loss. So quite devastating. So going back to the exam, That's one thing you want to rule out in the ER or the clinic, right? Do they have any vesicles in or around the ear, right? And what could you do to diagnose that? Just looking at them, is that enough? Or is there something else you could do to diagnose that?
So when you examine the ear, presence of the vesicles is pathognomic. If you have the other features, when you see vesicles, sometimes it will be a vesicular rash or a whole eruption with hyperemia, and usually they have a lot of pain. That's usually pathognomic for Ramsay Hunt. Your tuning forks will show a hearing loss on that side, a sensory neural loss. And then you have a facial nerve weakness, ipsilateral facial nerve weakness.
And if you're in a place that has a lab, you can swab the draining vesicles and send off for it's called PCR, right? You can actually look for zoster within that testing. Yeah, yeah. The key on that is if they're actively, if their vesicles are not crusted over, they're actively shedding virus. And so they're highly contagious. You want to keep them away from pregnant women, young kids, and the infirm or the elderly, right? It can be very dangerous. Yeah. Okay, good. So we're going to get steroids on board. And then I usually do like a burst and a taper, which there's a little bit of variation here. You want to do at least, you're going to put them on oral steroids, like 60 milligrams of prednisone a day for at least, 7 to 10 days, followed by some kind of a taper, maybe over the next week. Would you prescribe antivirals on top of that? And I'll throw it out to anybody. Any thoughts?
I think I wouldn't prescribe antiviral. From my understanding, this is a reactivation that
The antivirals alone or antivirals in combination or?
I'm just trying to figure out. Yeah, I'm just trying to extrapolate from patients that we've managed. I don't think we. I don't know.
I think it's controversial. I don't think the evidence has shown that it has a significant benefit over steroids or given alone. That's my understanding. I don't think it's strongly recommended. That's my understanding. I speak under correction, but that's my understanding. So I wouldn't give them.
Yeah, no, that's absolutely right. So you definitely do not use it as a monotherapy, right? Now, I mean, there's low side effect profile in antivirals. So in that patient that says, I can't take steroids at all, you could technically give her an antiviral, but it's not likely going to do much. But fortunately, antivirals have a low side effect profile. So they're really pretty safe, right? They're not usually causing any trouble. But if it's true Bell's palsy, you should not use this alone. And the oral steroids, you could offer oral antiviral therapy on top of, okay? But again, the data is really not that, doesn't really seem, now there's some interesting new data coming out now. So I'll be interested when we put this together for the update of this guideline, which will come out, like I said, in a year or so, about whether or not additional antivirals may be of some effect. There's some interesting data coming out that suggests that maybe there might be some added benefit beyond steroid. Now, what about go back to the Ramsay Hunt person? Are you going to withhold antivirals in Ramsay Hunt?
So no, I'll give antivirals in Ramsay Hunt. Mostly if you've seen the vesicular eruption or if you have confirmation from your lab testing that it's a zoster eruption, we'll give them the antivirals depending on what we have. Usually we'll give a cyclova, but that's not available. Then cyclova or cyclova also equally effective.
Yeah, so definitely indicated in Ramsay Hunt. We would describe them as like zoster-cidal doses. So people will put like acyclovir, like one gram, or like 1,000 milligrams, like 3 times a day for like 10 days, on top of the steroids, right? Max dose steroids.
I have a question. I have a question about the rungs in hand. Do you ever use the topical antivirals? Like if you have vesicles in the ear canal and you've cleaned out, do you ever apply the antivirus?
I've never
cream?
done anything topical, nothing topical, just oral, yeah. So high dose oral steroids, ostracidal doses of antiviral, eye care, baseline audiogram. Yeah, yeah. Now, we don't, in bells, we don't worry about audiograms, right? Because bells doesn't affect the inner ear, right? Yeah, okay, good. Okay. You already discussed this one, right? So the key on this, obviously, is this is really important. We talked about this already, is you really got to be vigilant with the eye care in these folks, right? You can't emphasize this enough to the patient. That's the most important thing. Although they're worried about the face, of course, but this is critical, right? So lacquer lube at night, tape the eye shut. The one thing about taping the eye is you don't want to tape it right over the front of the eye, right in the middle. Why is that?
When they tape right in the middle, sometimes the eyelashes evert and they can scratch the cornea.
Yeah, well, it could be the eyelashes, or if the eye drifts open, the tape doesn't work. The tape is right over the cornea. You can scratch the cornea. So you want to tape it on the lateral aspect near the canthus, lateral canthus. So if the eye drifts open, it's over the sclera typically, right? Less likely to do damage to the eye. Or you use one of these humidified eye chambers. I don't know if you guys ever use these at all.
No,
It's basically an eye patch that has a plastic shield with a little foam ribbing around the edge to create a seal, so people can see through it. But what it does is it seals the eye and everything around it. So any kind of moisture, as we sweat and this kind of stuff, it's trapped in there. It's like creating almost like a sauna around the eye. Like a a heated room, so to speak, with moisture. Yeah. So that's the whole idea.
I noticed that yours has a flat band on it, which is better than our round band. If you happen to know the brand name, I'd be interested to know the brand name on those, because I think those are better. That looks better than the one we
That's
use.
a good question, Brad. I don't know the brand name. Yeah. What he's getting at is this sits more, broad based on the skin. And because the round one's it's almost like a piano wire. You can, cut it, the skin, it can be really kind of like, you can get some necrosis of the skin. You got to be careful with really narrow things tightly pulling on the skin. Yeah. Yeah, I don't know. I'll have to look at that, Brad. I think it's been
unfortunately I have to jump off in 1 second here, but are you going to talk about decompression of Bell's palsy?
Yeah, we will get to it. We'll probably have to finish this, guys. So we'll finish this next week,
okay.
and Gift will go into some additional cases. How's that sound?
Yeah, good.
Oh, that's good.
Is that okay?
Yeah.
So it takes a little longer. Thanks, Brad. Have a good weekend. Well, hopefully maybe we'll see you tomorrow. I hope. Yeah.
Thank you. Unfortunately, I've got a commitment tomorrow again. So
Okay, sure. All right,
we seem to always hit the same day that I have this other thing going on.
Yeah, that's okay. All right, have a good
Thank
weekend.
you.
Thanks. Bye. No, guys, yeah, thanks. I know these take longer because I like to talk through all this stuff. So we will we'll pick this one up next week, and then we can do some cases. Okay, does that sound okay?
Yeah, that's fine. That's fine. It's always good when we do that discussions. Yes, it takes longer, but I think that's better.
It's helpful, yeah.
It's
But that's the
helpful.
important part of it,
That's
right?
to think through the cases, yeah.
Yeah. Well, we can. So, Gift, when do you take your exam?
I'm not sure yet.